Alrighty, good afternoon, everyone, and welcome to the Client-Centered Contraceptive Counseling Incorporating Reproductive Life Plan Model webinar hosted by HCET. My name is Meghan Arias, and I am the Training Manager at HCET, and I will be facilitating the webinar today. So let me briefly introduce you to healthcare education and training. HCET's mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. And HCET is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. So now I will quickly go over some housekeeping information before we begin. A link to complete an event evaluation will be sent to you in the chat at the end of the webinar, as well as following the webinar today via email. And your feedback is greatly appreciated. Archived presentations and a list of upcoming events can be viewed on our website. And if you have any technical difficulties during this presentation, please email updates@hcet.org. That email is listed on your screen. In order to receive nursing contact hours, a participant must attend the entire event, return the completed participant evaluation / post-test, and complete the nursing contact hour form and email it to kbradford@hcet.org. The presenter does not disclose any actual, potential, or perceived conflicts of interest. And throughout this presentation, we encourage you to send your questions via the chat box. And to submit a question, hover over the main screen, then select the chat icon at the bottom. Once that's selected, a chat box should appear on the right side of your screen. And to send a question at any time during the presentation, please send it to all panelists. This ensures that everyone who needs to see it can view your question. And we will hold all questions, reading and answering until the end. So now I'd like to introduce you to our presenter for today's webinar, Meghan Benson. Meghan is the Director of Education at Planned Parenthood of Wisconsin. She has been with the PPWI Education Department for more than 12 years, providing sexual and reproductive health education and training. Meghan is currently a PhD student at the University of Wisconsin-Milwaukee Zilber School of Public Health, and she serves as chair of the Dane County Youth Commission and secretary for the Wisconsin Alliance for Women's Health Board of Directors, and recently ended a 2-year term as co-chair of the Maternal and Child Health section, and serves as a member of the Conference Planning Committee for the Wisconsin Public Health Association. So without further ado, I will pass things over to Meghan.
Thank you, Meghan, and good afternoon, everyone. I am really excited to be talking with you today about client-centered contraceptive counseling and how to incorporate reproductive life planning into that process. So I did just quickly want to share the objectives. These were all set out ahead of time, so I'm not going to spend time reading through them, but just so everyone is aware of the plan for the next hour or so, these are the topics that we'll be covering. I do have a quick note on language. When data on race, ethnicity, sex, gender, or other demographic categories are presented, the categories used by the data sources will be reflected. I do want to acknowledge that demographic categories are socially constructed and that oftentimes people who may not identify with that category end up getting lumped in it anyway as we're doing data analysis. So I recognize that data is not perfect, it has a role to play, and I just wanted to acknowledge some of the challenges with it. I also plan to use gender inclusive language as we discuss clients seeking contraception and who are able to get pregnant. I acknowledge that this is something that I am changing in my practice. I have been working in sexual and reproductive health care for a very long time. I was very used to using words like women and female when I talked about things like contraception and pregnancy, and I really am in the process of making sure to use more gender inclusive language. However, I do still screw up, so if that happens during this presentation, I just ask that people call me in, let me know, and I'll do my best to adjust. So I do just want to start out by sharing a little bit of data with you all. I don't think this data is going to be surprising, so I'm not going to spend a whole lot of time focused on it, but just wanted to provide a framework for our discussion today. So we know that pregnancy unintendedness is actually a very complex concept. It may seem simple on its surface, however, it can be very challenging to measure, and there are a lot of critiques about the concept of pregnancy unintendedness. So we will be defining unintended pregnancy as a pregnancy that is unwanted or mistimed, whereas an intended pregnancy happened at the right time or later than desired. So part of the reason it's challenging to measure unintended pregnancy is because we generally only gather data for pregnancies ending in live births. We often assume that abortions are unintended. We also often assume that miscarriages are intended, which might not be the case, and also miscarriage data is often incomplete. Finally, the questions that we ask about whether or not a pregnancy was intended are asked retrospectively about intention prior to conception, and that can influence how people respond to those questions. So I just want to mention that the next few slides of data that I will be sharing with you are from research that was published 5 years ago with data from 10 years ago. I think this data remains important for a couple different reasons. First, the research done to obtain this data is really comprehensive. So it's combining data from the National Survey of Family Growth, a national survey of patients who have had abortions, data on births from the National Center for Health Statistics, and data on induced abortions from a census of abortion providers. So it's really taking a lot of different useful data sources and combining them into one so we can get a really good picture about what unintended pregnancy looks like in this country. In addition, this data was collected after 2011, and folks may remember that the country was just coming out of the Great Recession of 2008 and 2009. And the authors of the study did posit that some of the changes that they had seen in unintended pregnancy rates may have had to do with the economic downturn that we were experiencing as a country. And certainly as a result of the COVID pandemic, we are in similarly challenging economic times. And so again, I acknowledge this data is about 10 years old, but I think it remains relevant today. So in terms of racial disparities in unintended pregnancy, you can see that some communities of color experience higher rates of unintended pregnancy. I do acknowledge this data is a little limiting because the authors were pulling from so many different data sources. They weren't able to present data on other communities. And so I do just want to acknowledge that there are certainly additional data out there that shows that Indigenous communities, some Asian American communities also experience high rates of unintended pregnancy. Next, I just want to take a quick look at disparities across the lifespan in unintended pregnancy. It's probably unsurprising that unintended pregnancy is more likely to happen earlier in life, especially during those teenage or adolescent years. I do also want to point out, though, that not 100% of pregnancies that occur in teens or young people are unintended. And I do just think that's really important as we're thinking about counseling patients about contraception, as we're thinking about reproductive life planning, that we don't just assume that people in certain age groups are not planning a pregnancy. I'm guessing this is also unsurprising. We do see that people who are lower income have higher rates of unintended pregnancy, and we will definitely be talking a little bit more about why some of these disparities exist in just a second. And then somewhat related to income disparities, we do also see some educational disparities, although you can tell by looking at this data that does look a little different. So just important to keep in mind that people from different demographic groups with different characteristics have different experiences and different risks related to unintended pregnancy. So why do these disparities exist? A huge reason for these disparities are health inequities. These inequities are related to differences in access, experience, and opportunities related to healthcare, as well as education, and also the social determinants of health, things like employment, income, wealth, housing, policing, the environment, opportunities for civic and political participation, and many, many more. Also, distrust of healthcare and education, along with many other institutions, comes from a history and ongoing practices of abuse and coercion by our policies, systems, and environment. And that can definitely contribute to these health disparities as well. Other factors that influence health outcomes include cultural and community norms, acknowledging, respecting, and when appropriate, seeking further understanding of these norms is really important for building positive relationships with patients and clients. Another factor that contributes to unintended pregnancy is the idea of pregnancy ambivalence. So being unsure or feeling pulled in different directions when considering getting pregnant or parenting in the future. This is a really important concept and we'll be exploring more about it later. But first, I do just want to expand on the idea of access. So what makes healthcare, education, and information about contraception accessible? Certainly some of the immediate things that come to mind is, where are these services? When are they open? How is someone going to get there? How are they going to pay for them? Additionally, it's really important to consider the language that the patient or client wants to communicate in, their literacy level, making sure that our information and education is culturally responsive and inclusive, and also making sure that we're providing equitable information that is also tailored to individual clients. So I just want to take a quick minute to talk about equity. People have probably seen an image, this image or an image like it, and I do just want to remind folks that equality and equity are not the same thing. Equality is giving everyone the same thing in spite of the outcomes that they will have. And you can see from this top graphic that clearly all of these individuals are not going to have the same outcomes by being given the same bike. Equity, on the other hand, is giving people what they need in order to have more equal outcomes. So I do also just want to take a quick pause to think about the impact of the COVID-19 pandemic on fertility. So thinking back to the research that I just presented a minute ago, overall fertility rates are very likely to decline in this country and probably globally over last year and probably coming years. But I do think it's really important to consider, will this decline be equitable? So on the one hand, we might have people who prior to the pandemic were trying to get pregnant or planning to get pregnant soon. The pandemic hit, and these folks had access to information, resources, and healthcare services. That gave them the option to delay pregnancy, or perhaps not. I'm not saying that everyone who has access to information and resources has chosen to delay pregnancy. There are certainly people who have decided they are going to get pregnant during this pandemic for a variety of different reasons. But again, we have a group of people who have that option right now to delay pregnancy. On the other hand, we have a group of people who maybe were trying to prevent pregnancy before the pandemic hit, and they've decided they want to prevent pregnancy, and they have limited access to information, resources, and healthcare services. That means that they have fewer options to delay pregnancy. So again, we're probably going to see a decline in fertility in the coming years, but outcomes will really vary for different populations and different communities. So it's important for us to consider gaps in access. All right, so I have a little activity that I am going to ask everyone to participate in. So I'm going to go through 5 slides and I'm going to do it pretty quickly. On each of these slides, you are going to see an imaginary patient who can or who is at risk of getting pregnant. each slide will have a picture of the individual and some key information like their name, their pronouns, their age, as well as some other potentially relevant information, at least relevant to contraceptive counseling. So this might include some sexual health history, information about sexual behaviors, reasons for seeking contraception, or desires for future pregnancy or childbearing. So as we go through these slides, I'm just going to ask everyone to jot down your thoughts about the methods of contraception that are available to this individual. So I also know that a lot of you are going to want to ask additional questions as we go through this, this activity. So please also jot those down as well. So a few important notes. I mentioned that these are imaginary patients, and so the pictures of them that are included were free stock photos. And I just want to acknowledge they were a little limiting in many aspects of diversity, especially things like body size, ability, and gender expression. So I did my best to find some diverse images, but I really hope that people who produce stock photos start to do better. Also, again, only some information is going to be provided for each individual, which is often a reality in healthcare interactions, right? We only have so much time to interact with a patient. So as you're noting what types of contraception might be available for this person, please also note any follow-up questions that you might ask based on the information that I'm giving you. And then also as you're doing this activity, so again, jot down contraceptive methods, jot down questions you might, follow-up questions you might ask the patients. I'm also going to ask you to sort of consider the assumptions that you're making as you're doing this, and we'll talk more about that later. So there's no need to share your thoughts right now, although if you want to chat them in, you're welcome to. Mostly this is really just kind of a self-reflection exercise. So again, as you're able to, please take some notes for yourself. All right, so here is our first pretend patient. Gabriella, pronouns are she, her, 17 years old, diagnosed with and treated for chlamydia last year, and is expressing concerns about heavy and painful periods. So what methods of contraception might you consider for Gabriella, and what follow-up questions do you want to ask her? Next patient is Carmen. Carmen uses she, her, or they, them pronouns. They are 34 years old. They have no children with no plans for a future pregnancy, and they dislike the irregular bleeding they have been experiencing with the implant and want something different. And then we have Kiara. She uses she, her pronouns, 28 years old, wants to have children in the next few years, has never had regular periods, and expresses concerns about unpredictable bleeding. And then finally, oh, not finally, two more. We have Lisa. Her pronouns are she, hers. She is 45 years old, has 3 teenage children, and currently has multiple sex partners. And then finally, we have TJ, who uses he, him pronouns. He is 31 years old and would like to get pregnant at some point in the future, but is not ready to get pregnant right now. So I am seeing a chat that folks said they need a little more time to think about those. So I will go through them one more time. And again, I understand that as healthcare providers, you all want to know so much more. You want to ask lots of follow-up questions. And I recognize that I am only giving you a little snapshot of each of these individuals. So again, I'll go through them one more time, just in case folks need a little more time to think. So starting back at the beginning with Gabriella. And Carmen. Kiara. Lisa. and TJ. So hopefully everyone had a chance to at least jot down a few notes, and I'm just going to ask you all to kind of reflect on some of the things that you thought about for each of these patients. And let's consider how our experiences and our biases may impact our contraceptive counseling. So first of all, thinking back to the demographics or individual characteristics that were shared about each of these pretend patients, keep in mind what I didn't tell you and what you may have assumed. So did you assume that 17-year-old Gabriella wasn't planning a pregnancy? Did you assume that 45-year-old Lisa was done having children? I think that is probably something that I have definitely done during my time providing contraceptive counseling and contraceptive education. And it is just really important that we keep those biases in mind. We all have them. That's just how it is, being human, and that's okay. It's just important that we're thinking about them, and as we think about them, we're less likely to then provide biased education or counseling to patients and clients. So what other characteristics or information about these individuals made you consider certain methods over others? Did you think differently based on things like gender expression or age or race? And then what if these clients had also mentioned that they were uninsured or unsure about how they would pay for services? I recognize that some folks are coming from clinical settings where you may have programs like Title X, you may be able to bill Medicaid. So there are ways that you can help patients, some patients pay for their care. But just keeping in mind that payment, being uninsured can definitely still remain a barrier for some patients. So how might that impact how you are providing contraceptive counseling? Additionally, when I shared, again, some limited information about sexual and reproductive health behaviors and history, how did information about sex partners or sexual behaviors contribute to your considerations? What follow-up questions did you want to ask each of these individuals about their partners or about their behaviors? And did you also consider the role of STI prevention education in contraceptive counseling? And then finally, we all have biases based about different contraceptive methods that is really important to keep in mind. So our biases towards different contraceptive methods can then contribute to biased counseling. And oftentimes when we are counseling about contraception, our emphasis is primarily on effectiveness, and our own personal, professional experiences, preferences, expectations do play a role in how we're interacting with our clients. So we're going to spend a little time focusing on these two potential impacts on contraceptive counseling. So it's important to keep in mind that method effectiveness is not always the top priority for every contraceptive client. In this slide, I'm just sharing some information from a recent Planned Parenthood annual report. This is actually national data. So around the country, Planned Parenthood contraceptive patients overwhelmingly choose the pill, the ring, or the patch. Many folks choose to use barrier methods, which is great because they also prevent against sexually transmitted infections. And then two of for our patients effective methods. Effectiveness is absolutely
Thank you, Meghan. Can you hear me? Okay, perfect. I will read questions off. Hold on one second. Okay. If everybody wants to use the, to ensure that everybody who needs to see the questions use the all panelists feature 2 in the chat so that we can see all the questions that are coming through. And I will give everyone some time to do that. And it looks like we have a question in the chat at the moment. The question is how you would recommend discussing birth control with a teenager who says they are trying to get pregnant, but doesn't appear to understand how life-changing a pregnancy/baby would be.
Yes, thank you for that question. And I do understand that this can be a challenging situation to be in because we do understand that there are some pretty big hurdles for young people to get over when they are pregnant and parenting. I do just want to acknowledge that, pregnant and parenting teens can be very successful, can be wonderful parents. They may need some additional support. And luckily there are some supports out there for young parents. And I do acknowledge the challenges that you face early in your life when becoming a parent may be different than later in life. And so I think it's just really important to, again, ask those open-ended questions of this young person, why, tell me more about, your interest in getting pregnant. Asking why you want to get pregnant can sometimes sound a little judgy, but tell me more about your plans for getting pregnant or your plans for parenting in the future. Asking about how pregnancy is going to fit in their lives. So if they're in school, maybe having a conversation about, what is it going to be like to be in school and to parent at the same time. So again, it's really just about focusing on that individual, recognizing that you are there to support them, to provide information. When they walk out your door, they're going to be making their own decisions. They're going to be doing their own thing. And so lecturing a young person about why they shouldn't get pregnant is not going to be helpful. But again, offering those support, offering those resources, having a really authentic discussion with them about how pregnancy and parenting fits in with their life at that moment. And at the end of the day, that young person may decide to get pregnant and become a parent. And at that point, we just offer those resources that are available.
Thank you. And as we wait for some more questions to pop in, again, make sure to use the all panelists 2 at the bottom so that we can view your questions. It looks like another comment came back in, just thanking you for your approach to language diversity, inclusion, and self-acknowledgement of where you're at in the process. And then it looks like we have a question. Would recommendations change if a patient has experienced prior troubles to getting pregnant in the past?
I'm not quite sure I'm fully understanding this question. So if I'm not addressing it, feel free to chat in some clarification. But certainly if you have a patient who is interested in getting pregnant and they had a challenge with a past pregnancy, We do know it's more likely that there are going to be challenges with future pregnancies. And so for that individual, again, I think it's just important that you are having a conversation with them about other resources that are available. So assistive reproductive technology, adoption, other options that people might have if they want to have children in the future. The other thing about this question, though, that's really important is also that people can have trouble getting pregnant, maybe get pregnant, and then think, because it was so hard to get pregnant, like, I'm probably not that much at risk for pregnancy, so I probably don't need to worry about birth control. And again, even if someone did have problems getting pregnant in the past, and they're more at risk for having those problems in the future, it doesn't mean they will. And so it's still important, if that person isn't ready to get pregnant right then, that you are still talking to them about the importance of using contraception, even if their likelihood of getting pregnant might be low. It's not zero.
Great, thank you. And then another question is, how would you recommend talking with youth that want contraception but don't want their parents to know?
Yeah, I think that is such an important question. So thank you for bringing that up. I do think it is important when you are talking with young people that you do ask them about their parents or other trusted adults in their lives. Check in with them to see if there is someone they can talk to, someone that will be supportive of them. And you may even be able to help provide them with some suggestions for how to talk with parents or guardians or other adults in their lives. And yes, for some young people, that is just out of the question. They can't tell their parents or their caregiver. They need their contraceptive method to be private and confidential. And so I think just, talking through the different methods of birth control, right? Like, if you're interested in the patch, there's a chance a parent could see that patch. If I'm going to give you 3 packs of birth control pills right now, are you concerned about, keeping those in your sock drawer and somebody finding them? So I think it's just really checking in with them about that relationship with their parents, if there's anything that you can do to support a conversation. And if not, then really talking to that patient about, what are your concerns about your parents finding out, and what method of birth control might we be able to consider that will be a little more invisible, a little, harder for a parent to maybe find out about. So maybe that's the shot, maybe it's an implant. But yeah, really important conversation to have with young people.
Thank you. And as we give it another minute or two for any lingering comments or questions to come in, I do want to thank you, Meghan, for a wonderful presentation. I know there are some comments in the chat for you to read about how wonderful the presentation was. Again, I will just give it another minute or two for any last minute questions before we wrap up for the day.
Thank you, everyone. I really appreciate all the very kind comments that are coming in through chat, and really glad that I had the opportunity to be here today. So thank you to HCET for inviting me.
Thank you, Meghan. All right, we will move on for the sake of time. But again, you do have Meghan's contact information in the slides that were given to you before this webinar. So if you have any questions that do pop up, please make sure to email her. I'm sure she has the right answers for you. And then if you would like to go to the next screen for me, please. Again, if you enjoyed today's presentation and would like to learn more about other topics like sexual health concepts, consider visiting HCET's virtual learning at learn.hcet.org. New learning opportunities are being updated regularly. This sexual health concepts one covers the basics of sexuality and inclusive terminology for reproductive and sexual health, as well as reproductive and sexual health anatomy and physiology. So make sure to go to learn.hcet.org to learn more about those online learning modules we have. And again, thank you so much, Meghan. We appreciate you here at HCET for putting on a wonderful webinar and all the content that was covered. And I have put the Survey Monkey evaluation in the chat. Your feedback is greatly appreciated here at HCET. And we love to hear what you have to say. And look out for an email to follow up this webinar with any lingering information that you'll need to know. And thank you so much again, Meghan. And I hope everyone has a wonderful rest of their day.
Thank you. Bye, everyone.